Hello, it's Adam again, and today we're going to continue on with our lectures of the kidneys. This will be Nephrology Part 2. The first section we'll begin talking about is going to be drug-induced kidney injury. We've talked quite a bit about acute kidney injury, we talked about chronic kidney injury, chronic kidney disease. I want to talk a little bit more about some of the cases of drug-induced kidney injury and some of the things that we can do to prevent or mitigate some of the effects here. We kind of alluded to some of it in the Monday class, but we'll get more into detail with some specific examples today. So some of the manifestations of drug-induced kidney disease, some of the things you'll find occurring once the insult has occurred is going to be acid-base abnormalities. So certainly you can see things like an acidosis develop, electrolyte imbalances for sure, proteinuria, all these different things can occur. But the most common thing you'll see is going to be a decrease in the GFR and creatinine clearance. It's probably going to be the first thing you're really going to pick up on in the absence of any of these other issues that creep up here. So looking at why are we talking about this? And it's mainly because it's a huge issue. Like it occurs much more commonly than you may think. We know that community-acquired drug-induced kidney disease are responsible for around 20% of the hospital admissions due to acute kidney injury. And then in the hospital itself, you have a much higher proportion of that. So around 60% of the in-hospital acute kidney injury is going to be due to this, due to drugs. So the most common ones you'll see being a source of this are going to be including your antibiotics, certainly things like your aminoglycosides. NSAIDs will be kind of following up by that, ACE inhibitors. And then you also have some other agents, things like chemotherapeutics. We kind of talked about a little bit about how methotrexate is a fairly common one, and then also some antivirals, probably less common than you would see with things like the antibiotics and NSAIDs. So looking at the presentation, most commonly, as we said, is going to be a decline in your GFR. So again, you're going to be seeing that by looking at your rise in serum creatinine, and then also in your BUN. And so one of the things you should also remember, though, is to not just work off the numbers. Like we said before, we know that creatinine clearance is going to be one of those things that takes a little bit of time to really catch up to the kidney injury, because it takes a while for the creatinine to actually get back to steady state and increase after the decline in the kidney function has already occurred. But one of the things I never really realized until I was out in practice was that you can have issues where you will have basically renal tubular function that can occur, or dysfunction that can occur without a loss of GFR. So the kind of way I talk about these are dumb kidneys, where the patient's still producing urine, they're still appear to have functioning kidneys, but the kidneys aren't really working that well. They're not really holding on to electrolytes like they should. They are you may have some hematuria. Different things are going on, so the kidneys really aren't working that well. So even though your GFR is not going down, they're just not functioning appropriately. Again, some of the other symptoms you're going to be seeing with this include things like malaise, anorexia, vomiting, edema, especially patients who have poor cardiovascular function. Certainly you're going to see a lot of backup of fluids being secondary to this. Some other signs we can be seeing, so obviously looking at things like your decreased urine output with a progression eventually to developing more hypertension and volume overload. So certainly things like contrast-induced nephropathy or CIN would be involved with this here. NSAIDs, ACE inhibitors for sure. Some of the other things you can see, though, if you have a drug causing more proximal tubular injury, because of the fact that you're going to have some issues with the handling of bicarb, you can actually develop a metabolic acidosis. And this is because you're going to be having a lot of loss of bicarbonate in the urine itself. You can also see some increased sugar in the urine, and then you're also going to have a lot of electrolyte issues here. And so essentially, because you're having increased urinary losses, you can develop hypophosphatemia, hypokalemia, and hypomagnesemia. Typically with the distal tubular injury, it'll be a little bit different, where because you have an impaired ability to really concentrate the urine, because that from the ascending loop of Henle on is where you have a lot of the concentration occurring. If you have a loss there, you're going to be seeing more polyuria, so that's where you can still see, pretty decent urine output, even though the kidneys are not really holding on to things appropriately. Um, and so here's where you can also develop metabolic acidosis because you have a harder time actually acidifying the urine. And actually here, what you might end up seeing potentially is hyperkalemia developing. So a little bit different kind of presentation from the distal versus the proximal. So looking at drugs that are going to be more commonly causing acute tubular necrosis, as we mentioned, that's going to be one of the most common intrinsic causes of acute kidney injury. So some of the big ones you should always really keep on the front of your mind are going to be your aminoglycosides, especially in your septic ICU type patients. Radiographic contrast media, for sure, is going to be another huge one. And then looking at drugs on the chemotherapy side, things like cisplatin and carboplatin. And then another one, an antifungal agent we probably haven't talked too much about previously, but a drug called amphotericin B, which is utilized for more severe fungal infections. Certainly you see it in certain immunocompromised patients, so things like in the hemonc unit or in the ICU, you may see this drug being used, and notorious for causing a lot of kidney issues. Some other agents you might see being involved, things like cyclosporin and tacrolimus, which are transplant medications or immunosuppressants. And then you have a lot of agents, antiviral agents like adefovir, cidofovir, foscarnet's another antiviral agent. Mentioned zoledronate just a few lectures ago when we talked about medications utilized for hypercalcemia due to hyperparathyroidism, and also pentamidine, which is a can be a treatment medication, is most often utilized as preventative therapy for things like PCP pneumonias in at-risk patients. Some other issues you can see pop up from drug-induced kidney injury are going to be a phenomenon called an osmotic nephrosis that can occur. This is typically from items that have a very high osmolarity that are drawing a lot of water into the tubules, which can cause some damage to occur over a longer period of time. So things like mannitol, dextran, and potentially even IV immunoglobulin. This one's definitely less common, but it's something that may pop up occasionally. And then we've already talked a lot about our hemodynamically mediated kidney injuries. So this can be more on the side of kind of a prerenal kidney injury in some cases. So certainly ACE inhibitors and ARBs fall in this category, or NSAIDs will be working here as well. And even drugs like I mentioned before, cyclosporin and tacrolimus can be responsible for this as well. Then looking at drugs which can cause an obstructive nephropathy, remember this is going to be kind of the post-renal side of things. It can be somewhat intrinsic or post-renal. So if you have an intratubular obstruction, so these would be medications that are going to be precipitating out within the tubules to cause an obstruction. So acyclovir is pretty well known for this, can cause a crystalluria leading to obstruction. Certain sulfonamides, things like potentially Bactrim or sulfamethoxazole. And then another big one is going to be methotrexate, which is again seen with, especially with your higher doses. You're going to be given this with bicarbonate pretty frequently to help alkalize the urine to prevent it from precipitating out. So certainly, like when you see like your big doses being given for chemo patients, that's where you see a lot of bicarb-containing fluids being involved. And then some drugs can cause more of a nephrolithiasis, things like your sulfonamides, triamterene, which remember is a potassium-sparing diuretic, and then indinavir, which is a antiretroviral utilized for treatment of HIV. We have some drugs which will actually specifically affect the glomerulus. This can include things like your NSAIDs, pamidronate, lithium, even remember lithium being utilized for bipolar disorder. But surprisingly enough, gold can cause some issues here. Gold actually used to be utilized as an anti-rheumatologic agent. It has more immunosuppressant effects when given intravenously. But it's also pretty toxic on the body. So gold compounds have kind of gone by the wayside when we've had more effective medications, things like methotrexate or things like your monoclonal antibodies. So those you won't see pop up too often. And then you also have some patients who can have an acute allergic interstitial nephritis. Again, this is not super common, but certainly anything that you may have an allergy to can affect this. So penicillin's a very big one. NSAIDs, loop diuretics can all potentially be a cause here. Some other drugs which can potentially cause vasculitis or thrombosis. So hydralazine can be a really big one for this. Hydralazine can cause kind of a drug-induced type lupus type reaction and vasculitis. So hydralazine can be big here. Hydralazine, as you remember, is a antihypertensive. It's a direct vasodilator. Allopurinol can be seen to cause this as well. This is typically used as an anti-gout agent, and then things like cyclosporin and methamphetamines as well. And then kind of a rare thing you may see would be a cholesterol emboli, which can form, which it can be seen with certain thrombolytic agents or warfarin. So looking at the drugs that are going to be causing tubular epithelial cell damage, essentially what they're going to be doing is either causing ischemia to occur, which will lead to cell damage and death, or direct cellular toxicity. You'll often see it localized either to the proximal, or often localized to the proximal and the distal tubular epithelia. And essentially what's happening is when this damage is occurring, you're going to have a lot of cellular degeneration, necrosis, and you're going to be sloughing off those base membranes. So because of that, that's where you can get a lot of those casts that are going to be forming and have this kind of cellular debris, kind of muddy brown cast being developed. So as we said, acute tubular necrosis is going to be one of the more common presentations of drug-induced kidney disease in the inpatient setting. So again, the big agents are going to be related to causing this are going to be our aminoglycosides, contrast media, cisplatin, and amphotericin. We'll talk a little bit more specifically about these and how they're causing this and how we can potentially treat this. So aminoglycosides themselves, again, we can see some degree of acute kidney injury in 10 to 25% of these patients receiving a therapeutic course. Obviously, if you have a very sick, critically ill patient, that's going to go up, especially since they're already more likely to be hyperperfusing anyway, and are just at bigger risk for developing kidney damage. Typically, it's not going to occur immediately, but you may see it pop up, say, a week into therapy or 5 to 10 days or so after you see this initiation. And generally, the first thing you're going to notice is this progressive increase in BU and serum creatinine, and also you're going to see that decrease in urine output. Usually, the urine output is going to go down before you see the BU and serum creatinine, so that's always one of the big things we want to look for. And then generally, if it's going to be recognized early enough and you can discontinue therapy, it can be completely reversible. It may take a little bit of time, may take a few days to weeks for it to come back, but it certainly will come back in the majority of cases. So the reason why this occurs is primarily due to having a high drug concentration. So certainly if you have accumulation of this drug within the proximal tubular epithelial cells, they're going to have direct damage to the cells by causing generation of these reactive oxygen species. And we've kind of alluded to these before, but reactive oxygen species have a way of damaging things like mitochondria, and they'll damage proteins and cause them to denature, which will lead to cell death, just due to the fact they're so reactive, and they end up kind of binding to a lot of different things and causing kind of a lot of havoc to occur. And so some of the risk factors that are going to be involved with ATN and caused by aminoglycosides are going to be things like large total dose. So they're receiving kind of a bigger dose throughout the day. Obviously, they're getting more prolonged therapy. And then higher trough concentrations are going to be the big thing here. So as you remember, aminoglycosides are going to be they're going to be concentration dependent killers. Right, so they're going to be focusing more on having a really high peak, and then you don't really need to have a trough that's above the MIC of the bacteria, because that's not how they kill. They have this nice post-wave antibiotic effect where you get that level really high, they kill off the bacteria, and then even if it gets down to zero, you're generally covered for a good period of time before you need to really redose again, as compared to a time-dependent killer like a penicillin, where you always want to have a trough concentration that's going to be above the MIC of the bacteria. So here what we end up finding is that with aminoglycosides, if you have higher trough concentrations, showing that you're having accumulation within the blood and also within the kidneys, that's when you're more likely to end up seeing acute tubular necrosis occur. And then obviously anytime you're adding on concurrent nephrotoxins, you're just increasing your risk for developing more toxicity. So more nephrotoxins, you're going to see more issues are going to pop up. So oftentimes and you're covering for significant infections like bacteremia or sepsis, you're going to be using gram-positive and gram-negative coverage. So oftentimes it's not uncommon to see a vancomycin in addition to aminoglycoside, and both of those can be pretty synergistic and leading to more kidney injury, especially if you're not watching your levels very closely. So looking at prevention of ATN caused by aminoglycosides, some of the things we can do is hopefully try not to put a patient on an aminoglycoside. That would be the best way to prevent it. But so in a lot of cases, that's not always going to be possible. So you want to make sure you're having careful patient selection on who you're going to be using this for. So if you already have a patient who has really bad kidneys or potentially is on dialysis, probably not going to be a great option to utilize an aminoglycoside. But sometimes you're kind of stuck therapeutically and you're going to have to use one regardless. So it's one of those things you're just going to be expecting it to occur, and you try to mitigate it however you can. Also look at limiting concurrent nephrotoxin usage. So if you have a patient who's at risk for developing kidney injury related to aminoglycosides, perhaps don't put them on an NSAID. Maybe acetaminophen might be a better option for pain management in that case, just due to the fact that the NSAIDs can compound the nephrotoxic effects of the aminoglycosides. We also want to do prospective pharmacokinetic monitoring, which is essentially a way of looking at the patient, taking in all their kind of characteristics in regards to size and weight, existing renal function, all of that, and dosing the drug based off of what we find. So, if you have a patient who already has a set of bad kidneys, you may not do once daily dosing. You may do every 36-hour dosing or every 48-hour dosing, depending on what kind of parameters they have going on. And then one of the biggest things we've done to limit the amount of nephrotoxic effects we have is once daily dosing. So as I mentioned previously, with this being a concentration dependent killer, things like gentamicin, tobramycin, because they just require having really high levels in order to kill the bacteria and they have that post-antibiotic effect, traditionally you'd see aminoglycosides being utilized Q8 hours. And so instead we can just utilize Q24 hour dosing, and especially most patients with healthy kidneys, and that gets a really nice high level. Essentially you're getting a very high level, kill out the bacteria, and then by the time you were to get a trough level in those patients, it would actually be undetectable. And so this helps to reduce that accumulation because the patient never really hits a steady state because they're always going to be metabolizing all of the drug off back to zero. And then in regards to the actual treatment, once we have acute tubular necrosis occurring, the best thing to do is just to discontinue therapy and wait for that reversal of the effects to occur. One of the next big causes for acute tubular necrosis is going to be our radiographic contrast media induced nephrotoxicity. Now, the incidence has definitely gone down over the past decade. It used to be around 15% or so, down to 7% over the last decade. And these agents still end up being, though, around the third leading cause of hospital-acquired acute kidney injury, so around 11% or so of those cases. So if you have a patient who has good normal functioning kidneys, like I'm sure most of you guys do, you're going to see less than 2% of patients who are receiving contrast dye. So, especially in the pediatric hospital, you really don't see a ton of this occurring because most of our patients have pretty good kidneys for the most part. But if you have a patient who has chronic kidney disease, maybe are dialysis dependent, it may happen up to 50% of cases. And again, it's a spectrum. It's not going to be all of a sudden you have no kidney function, but it could be just a hit, where you have a mild bump in your serum creatinine. That would still count as some degree of nephrotoxicity here. And then looking at patients who have developed contrast-induced nephropathy, they actually end up seeing a pretty high risk for death involved with this, 5.5-fold increased risk. And a lot of that could be related to other factors with the patient. What was going on to lead them to have such bad kidneys in the first place. Obviously they're going to be higher risk for death regardless. So one of the things they did at least note in the studies they've done there. So the presentation is typically going to be transient in nature, around typically peak around 24 to 48 hours after the administration of the agent occurs. And so typically what you'll be reporting in the high risk patients are going to be oliguria developing first. The way that this is going to be occurring is related to renal ischemia and direct cellular toxicity. So what occurs is essentially you end up having a 50% reduction in renal blood flow for several hours that can occur. Again, that's why a lot of these injuries occur 24 to 48 hours as this damage is kind of happening in the early onset. And essentially what that's occurring is by having less renal blood flow, you're going to end up having increased renal concentrations at the contrast. And then also one of the big issues is having this high osmolarity. A lot of the agents may have 600 to 2,000 milliosmoles per kilo. You guys remember what a normal um, osmolarity for patients are, could be like 280. So again, some of these things are very, very high osmolality, which can cause some pretty significant damage to the cells there. So again, risk factors are going to be pre-existing kidney disease. Certainly those that have creatinine clearance less than 60 are at higher risk, and anyone who's having a reduced renal blood flow. So this is where you have, say, someone starting on an NSAID or an ACE inhibitor at the same time, increases their risk for sure. So for prevention, anytime your patient's going to be getting contrast, you want to make sure you're assessing your risk factors for all of your patients. So um, in regards to the actual contrast we're going to be utilizing, we want to minimize the dose used, which may not always be possible depending on the type of scan we're doing. So certainly large IV doses to try to scan the brain or the lungs. You're going to be using pretty high doses, so try to minimize where you can, which might not always be possible. And then utilize either low or isoosmolar contrast agents, of which there are more plentiful nowadays, and so that's led to a big decrease in the incidence of this. And then also using non-iodinated contrast studies. And then obviously avoid concurrent nephrotoxins. This would be a big thing where you want to avoid things like metformin, because again, if you do have occurrence of contrast-induced nephropathy, you're going to be seeing a big increase in your accumulation of metformin, which can be an issue. And if you can, try to avoid any other nephrotoxins at the same time. Another thing we can try utilizing to help prevent this from occurring, and this basically helps to increase renal blood flow, helps to kind of dilute out the agent a little bit, is by giving us some isotonic crystalloids. So again, your lactated ringers, your normal saline, by giving a few hours prior to the contrast exposure and continuing that with some pretty healthy maintenance rates of fluids for that 6 to 24 hours post-dose, you can generally see a reduction in the incidence of contrast-induced nephropathy occurring. Some other things, some people feel that you may be able to get some benefit by utilizing sodium bicarbonate. They feel that by preventing the pH-dependent free radical formation, you can help to limit some of the damage being done. But unfortunately, studies are kind of controversial in that manner. Some people report some success, others don't. And then another thing we can try is N-acetylcysteine or Mucomyst, which I mentioned at the other lecture. Again, this is a good, safe drug, relatively cheap when given by the oral route. And so the patients you're going to see the most benefit in are going to be those that are at the highest risk for nephropathy to occur. So those are the already pre-existing renal disease. Like those are going to be the guys you typically want to treat beforehand with some Mucomyst. Again, management, typically the contrast dyes are going to be kind of a one and done type procedure. So once it's done, once the damage has happened, you kind of can't do much but just provide good supportive care. Again, trying to limit other nephrotoxins from being on board after this period is going to be a good way to help prevent this, or a good way to help kind of speed up the recovery process as well. Moving on, then we have cisplatin-induced nephrotoxicity. Cisplatin is a pretty widely used drug for a lot of solid tumors. I don't see a ton of it over in the pediatric side of things because usually we're treating a lot of leukemias, but certainly for some things like osteosarcomas or brain tumors and different things like that, you may be able to see cisplatin being utilized. And the major dose-limiting toxicity we're going to see here is going to be the nephrotoxicity. Typically what you end up seeing is going to be this kind of impaired tubular resorption, and so you're going to be seeing decreased ability for the kidneys to really concentrate the urine. So you're going to be seeing polyuria, decreased GFR, and then a lot of electrolyte wasting. So you're going to see hypomagnesemia, hypokalemia, hypocalcemia. And so the way that this occurs is people feel it is accumulating within the proximal tubular epithelial cells. And again, it's a cancer drug. It's meant to kill cells off. It's going to be inducing a lot of the cell damage and apoptosis in those areas. So for some preventative strategies we can utilize, again, prevention is always going to be the best best method. We'd like to try prospective dose reduction and decreased frequency. So some of your protocols you'll see may have decreased doses compared to what was used previously. And again, avoiding concurrent nephrotoxins. You'll notice this is kind of a running theme of trying to limit as much exposure to these agents as possible. And then do really vigorous hydration with NS, normal saline. That's going to be your best bet to prevent toxicity from occurring. So again, 12 to 24 hours, you're going to be seeing pre-hydration fluids, where they get lots and lots of fluids to help kind of tank them up. And then for 2 to 3 days after, your idea is you want to have at least 3 to 4 liters of urine a day being produced. This is going to help to kind of flush out the drug a little bit more quickly, help to dilute it out, and help prevent that toxicity from occurring. Another drug, which can be kind of an antidotal agent, would be is amifostine, which is a chelator, just meaning that it's going to bind up the cisplatin within normal cells. And so this one can be given 30 minutes prior to the cisplatin initiation, and is going to be able to help kind of bind up the drug while it's in the kidneys and help get rid of it without causing any damage. Usually you're going to see this utilized in your more high-risk patients. So typically, patients with normal functioning kidneys, usually hydration is enough for them. You don't necessarily need to use the amifostine. This has some adverse effects, so if given too quickly, large doses, you can see hypotension, and then nausea and fatigue can occur as well. Once cisplatin has done its damage, treatment, you'll generally see that this is going to be partially reversible. In some cases, you may have some significant damage that may not be reversible over time. In some cases, supportive care is not enough. You need to initiate renal replacement therapy with things like dialysis in some cases. So, in addition to this, you're just going to be replacing electrolytes as needed, and just making sure everything's kind of brought back to within a normal level. Another drug that can commonly cause renal toxicity is going to be amphotericin B. This is an antifungal agent. Again, you're going to see it used mainly in your really critically ill patients or your immunosuppressed patients, like hemonc patients. You can typically see, especially with just the base product, nephrotoxicity can be anywhere between 30 to 80% of your patients. And so you'll typically see it presenting as renal tubular acidosis and also a lot of wasting of potassium, sodium, and magnesium. Typically, it's going to be dose related, so the bigger the dose, the more likely they are to see toxicity occur, and it can occur days to weeks after the initiation of the drug itself. The way this is going to occur is by direct tubular cell damage, and so it's actually going to be interacting with ergosterol, which is the way it works to kill off fungus. Well, this is also a compound that humans do have to some degree, and so by interacting with that ergosterol in the cell membrane, it's able to damage the cells and cause that inability to really hold on to those electrolytes. And then also you can end up seeing afferent arteriolar vasoconstriction, so that can again limit blood flow to the kidney as well, causing some damage there. So risk factors, obviously, if you have pre-existing kidney disease, that can be a big issue. Large cumulative doses will also put you at risk. If you infuse the drug too quickly, again, it's going to lead to higher concentrations, higher peaks, so that can be a problem. And then obviously concurrent nephrotoxins are an issue, and then the patient's volume depleted as well. Again, it's going to lead to more concentration of the drug in the kidneys. It's going to lead to problems. So one of the things that they've actually done in order to help limit the toxicity that we're going to see here is by having a liposomal formulation. And so amphotericin B in this formulation is going to be called Ambisome. There's a few other liposomal preparations, but this is the one I'm most familiar with. And so essentially what happens is you have this kind of phospholipid bilayer. It's kind of this little spherical kind of fat kind of globule that is being impregnated with the amphotericin molecule. So you can kind of see it in the picture here. It's kind of this hollow sphere, and you just have the drug kind of sitting there within the lipid bilayer. And so by doing that, helps deliver the drug to the site better. It's able to get to the fungus and kind of kill that off better. And also limits a lot of the renal interaction that can occur. So it really helps to limit a lot of the toxicity that you end up seeing. Still possible, but it's less likely to occur. The big downside with utilizing this is it's very, very expensive. So amphotericin B maybe around $5 a day of therapy versus liposomal ambisome is going to, or liposomal amphotericin B can be around $300 to $1,000 a day. It's a big price difference there, but the cost of having to put someone on dialysis, going to be a lot more than that $1,000 a day is. So because of that, it's generally seem to be worth it. Also helping prevent this by giving adequate hydration. So good hydration fluids before administration is useful here, and then also extending out the infusion time can help prevent that as well. Treatment mainly supportive, mostly is going to be reversible, but may not be in some cases. And again, because we're going to be wasting a lot of electrolytes, replacing those as needed. Next, looking at drugs that are going to cause intratubular obstruction. Again, this is going to be precipitation of actual crystals of the drug in the distal tubular lumens. Again, this can cause intratubular obstruction. It's going to be causing interstitial nephritis as well in some cases, and then you'll have this kind of acute tubular necrosis that ends up getting superimposed on this as the damage occurs to those cells. So again, the pathogenesis is just going to be this direct precipitation of the drug, but in some cases you may have kind of an indirect promotion of release and precipitation of different tissue degradation products, which can lead to this obstruction. So it's not necessarily the drug that's precipitating out, but it's going to be some of these cellular byproducts that are caused by medication. So a good example of this would be something like tumor lysis syndrome, where you actually have precipitation of uric acid crystals occurring in the urine, as things, especially like leukemias and things like that. As you lyse all those cells and they break open, they're going to be releasing a lot of uric acid, and so when those get broken down and they get into the kidneys, they precipitate out and cause that obstruction. Typically, you see things like this being prevented by things like good hydration to keep it in solution, and then also utilizing a drug called allopurinol, which helps to prevent the production of uric acid crystals in the first place. In some really severe cases, there's actually a drug called glucarpidase, which can actually be utilized to directly cleave and break down uric acid into byproducts which are not soluble, or which are very soluble and won't precipitate out. That drug, though, can cost, I believe the last patient we had to use it on, was right around $98,000 for a single dose. So super, super expensive. Not something you want to have to use if you can prevent it. Another good example would be rhabdomyolysis. You can see a precipitation of myoglobin after a lot of muscle breakdown has occurred, and this can be related to things like having an HMG-CoA reductase inhibitor on board, along with a CYP3A4 inhibitor. So again, having those high concentrations of the HMG-CoA reductase inhibitor, like your simvastatin, leading to muscle breakdown and rhabdo that precipitates out and cause pretty significant kidney injury. And then acute kidney injury itself may be a cause for the drug precipitation. So sometimes the AKI will occur, which leads to drug accumulation in the kidney, which will lead to further damage to occur. So again, cases where you have kind of low urine volumes leading to lower drug solubility, and that can just lead to more volume depletion and just kind of propagates itself over time. So some of the big things you'll see here that can be related to this would be like things like acyclovir, methotrexate would be a big one. Then if you had like high calcium levels in addition to phosphonate being on board. Next, we're going to move over to probably everyone's most exciting topic of the semester. It's going to be disorders of sodium homeostasis. This is a thing that we'll see a couple of new drugs being involved in management of this, but I think it's a really important concept to have down of different ways sodium's handled within the body and how to manage those issues, because a lot of things can be precipitated by some of these drugs, and you'll see some issues here and there related to pharmacology. It's also super confusing in a lot of ways, and I had a hard time. I always have a hard time wrestling with these, so I think it's a good subject to cover. So we'll talk about this now. So looking at sodium and water homeostasis, essentially looking at a person, they're going to have some degree of total body water, and that can be broken down into where the water is being held up at. So typically for a patient, they would have around 60% total body water being within the intracellular compartment. A lot of the solutes that are holding water in the intracellular compartment are going to be things like potassium, organic and inorganic phosphates. That's all the solute that is keeping the water there. On the outside, though, in the extracellular compartment, which is around 40% of your total body water, you'll see things like sodium, chloride, and bicarbonate helping to keep that water volume there. So this is helped to be maintained with the help of that sodium potassium ATPase pump. We've talked about this in numerous places like the heart helps to maintain electronegativity there, the brain, different places, but it's also really important to help maintain this homeostasis between sodium and potassium, keeping potassium in the cells and keeping sodium out of the cells. And so typically what you end up seeing is that the osmolality is going to be pretty equal between the intracellular fluid and the extracellular fluid, meaning that water kind of permeates freely. It's not really being drawn one area versus another. And you'll see when you have changes in this osmolality, it's going to cause water to shift. This is where you're going to see a lot of problems creep up. So looking, we kind of talked a little bit about normal saline. We know that that's going to be an isotonic fluid because if you remember, normal serum osmolarity is around 280 or so, and isotonic fluids like normal saline, has 154 milliequivalents per liter of sodium, 154 milliequivalents per liter of chloride, right around normal isotonicity with the serum. So when you give fluids like this, you generally are not going to see really any net shift in the ICF or the ECF. Basically, everything's going to stay put, and so you'll see that isotonic fluids are typically going to end up being kept within the intravascular space. Some of it are going to partition out, but in general, you're not really going to see a big net shift here. Looking at hypertonic solutions, where you have things that are higher percentage than 0.9% sodium chloride, so say for instance you had a trauma patient who's having cerebral edema, you'd want to use a hypertonic solution, something like 3% sodium chloride. What this is going to do is to have higher solute concentration within the serum, and that's going to draw water out of the intracellular space. Out of the intracellular fluid and cause an increase in the extracellular fluid. So that's going to help draw water out of the CNS, it's going to draw water out of the tissues, and lead to more to be in the intravascular space. On the opposite hand, though, if you have a hypotonic solution, something less than 0.9%, say like half normal saline or 0.45%, that's going to lead more water to shift in the intracellular direction, and so you have a bigger balance of water being kept in the tissues. So looking at some of the different common fluids you see being given in a healthcare setting, just to compare where a lot of the fluids are going to end up after administering this, you'll see with something like dextrose 5% in water, D5W, again, not a whole lot of electrolytes there, actually no electrolytes, all going to be dextrose. And what happens is that dextrose gets broken down pretty quickly within the body over to CO2 and water. So what that essentially means is that by giving a liter of D5, you're basically giving a liter of free water that's free to go wherever it's going to go to, meaning that it's going to go to an area of high solute concentration in order to help dilute that down. Just normal passive diffusion happening there. So what you end up seeing is that you're going to have a higher percentage of the fluids going to end up going to the intracellular space versus going to the extracellular fluid. So because of that, you end up seeing a little bit more shift towards the intracellular fluid intracellular fluid space. And so because of that, you end up having issues with patients who say already have pre-existing edema. It's not going to be useful for patients who are intravascularly depleted because more of the water is going to end up in the intracellular space. Compare that to something like 0.45% normal 0.45% sodium chloride or half normal saline. You see here it has roughly around 77 milliequivalents of chloride and sodium. It's still a hypotonic solution, but here you only have about half of a liter of free water because of the fact that solute, the sodium and chloride that you're giving within the solution, when you place that into the intravascular space, it's going to hold on to some of that water there. But about half of it is still going to be able to kind of disperse wherever it needs to. So you end up seeing a higher percentage of it being kept within the extracellular fluid space as opposed to all transitioning over to the intracellular space. Then comparing that to agents which are going to be isotonic, things like Ringer's lactate or 0.9% sodium chloride or normal saline. You see here because they have a higher solute concentration, there's really no free water. If you're adding fluid to the intravascular space, you're going to see it stay there because the solute concentration is high enough to keep all the water right there. So basically by doing that, if you had someone who is intravascularly depleted, this might be a good option to give normal saline. Versus if you have someone who, say, has had pretty significant gastroenteritis or diarrhea, and they have a lot of depletion of their intracellular fluid, perhaps giving something like half normal saline will help to kind of replete some of that, more so than you would see just by giving the sodium chloride. And then if you had something which was hypertonic, which you can notice the concentration of sodium between normal saline and 3% normal saline, this is very hypertonic, and so you're going to see this be drawing a ton of water out of the intracellular space. So that's where you see that negative number there, because it's actually going to be drawing water into the extracellular fluid, and that's where you can help with things like cerebral edema by pulling water off the brain, essentially. So normally, serum sodium is pretty tightly regulated, and it helps to determine mostly your plasma osmolality and your blood volume. And the kidney is going to help to regulate water excretion usually through hypothalamic feedback here. The goal is to help maintain your normal serum osmolality somewhere around 275 to 295 milliosmoles per kilo. Obviously, this is going to change greatly depending on the clinical situation of your patient, but in general, this is where your patient is going to be sitting at. You'll also notice that osmolality will be affected by things like glucose and BUN as well. So when we're doing measured serum osmolality, you'll actually, or calculated serum osmolality, you'll also be factoring things like your glucose and your BUN in addition to your sodium in order to help establish what that calculated number is. A part of that hypothalamic feedback is going to be the hormone arginine vasopressin, or AVP. Another name for it is going to be antidiuretic hormone, or ADH. You may see it being abbreviated as, and this is going to be released from the pituitary in the response to increased osmolality. So say for instance you're having significant dehydration due to vomiting or diarrhea. When you have increased concentration of sodium within the serum, that's increasing the osmolality, and when your brain senses that, it's going to say, hey, I need more water in here. I'm going to be releasing antidiuretic hormone. What that does is going to help to bind to vasopressin receptors on the renal tubules, and this will actually help to insert aquaporin channels into the tubular lumen surface. These aquaporin channels are going to be very useful for stimulating water reabsorption, and also stimulates the brain's thirst response. So you're going to be intaking more water and also reabsorbing more water. And this will also help to stimulate the renin-angiotensin system, to help, because again, if you're having depletion of fluid volume and leading to hypotension, this is also going to ramp up the renin-angiotensin system to help restore that by increasing intravascular volume. So hyponatremia will be the first thing we'll talk about, and then this is going to be associated with either a normal, increased, or decreased plasma osmolality. So I get my laser pointer out here. You'll see the first thing you're going to be assessing when you have a patient with hyponatremia is going to be the serum osmolality. So when you have a normal isotonic hyponatremia, so your milliosmoles are going to be around 280 or so, you'll see this is most often caused by a pseudo-hyponatremia. Talk about that in a little bit. If you have a low or hypotonic hyponatremia, this is where you're going to be looking at the fluid volume status of the patient. Just to bring it back to when you had an elevated osmolality, if you have a hypertonic hyponatremia, most often this is going to be due to increased levels of osmoles in the blood. Most often it's going to be hyperglycemia, so certainly like diabetic ketoacidosis or hyperosmolar hyperketotic syndrome can be a big cause of this one in particular. But looking at the hypotonic hyponatremia, you have to look at the volume status of the patient. And so if you're looking to see either the hypovolemic, hypervolemic, or euvolemic, and then based on some of the urine testing, you can figure out there's some other issues going on, which we'll get more into detail on these in just a moment. So if you had a patient who had hypertonic hyponatremia, essentially what this is going to be showing you, there's a presence of excess effective osmoles within the serum. Again, like I said, most commonly you're going to see this as a hyperglycemia. And so glucose is going to be providing high osmolality. And so again, when the serum osmolality is high, it's going to be shifting fluid from the intracellular fluid to the extracellular space. And so by doing this, by glucose causing the big shift of fluids, ends up diluting your serum sodium concentrations. And so this is a pretty predictable phenomenon. Generally, for every 100 milligram per deciliter increase in glucose, you end up seeing your serum sodium drop by about 1.7 milliequivalents per liter. Other osmotic agents can do this, things like mannitol, but again, like I said, your diabetics are going to be the most commonly ones you see have this phenomenon occur. So really, your serum sodium may not actually be it'll read low, but it may not, total body concentration of sodium may not actually be that low unless you're having like some increased losses due to polyuria or something like that. You're going to see your hypotonic hyponatremia is typically going to be most common and generally has the most number of causes that can occur. And so again, like we mentioned, when you have this happen, you want to look at the patient's volume status to figure out if they're hypovolemic, euvolemic, or hypervolemic, because the causes of that are very different depending on the fluid status of the patient. So looking at a hypovolemic, hypotonic hyponatremia, this is going to be your patients who again are going to have lower plasma volume, they're hypotonic, and then the sodium is going to be low, right? So generally this is going to be due to excessive fluid loss. So you see this most commonly with things like diarrhea, vomiting, or if you had like something like diuretics, either higher doses being utilized for chronic periods of time, or even some patients will actually abuse these for weight loss purposes. You can see this. This is going to be causing a stimulation of AVP because again your body's sensing that the plasma volume is low, so it needs to hold on to more fluids. And so when this happens, when you have AVP start to increase, it's going to stimulate that thirst response. And so what happens is the patients will end up drinking hypotonic fluids, so things like water or things like Gatorade, things like that. And they can actually end up worsening the hyponatremia by diluting out the serum. Generally, when you see this occur, you're going to have generally high urine osmolality due to AVP helping to concentrate the urine. Because again, remember the aquaporin channels are pulling water out of the urine, so it's generally going to be pretty concentrated urine you're having there. And you can see this relatively commonly with thiazides, although most of your patients are generally going to be asymptomatic because your body kind of gets used to it over time and it kind of regains this kind of homeostatic nature to kind of get back to a point where the fluid volume loss is not so much that's even noticeable. So if you have a patient who has euvolemic hypotonic hyponatremia, essentially what you're seeing here is the patient has basically a normal amount of sodium in the extracellular fluid, but what's happening is you're having an increase in your total body water and in the extracellular fluid volume. So what that's doing is actually diluting out the sodium that's there, even though it's relatively a normal amount. And generally, you're going to see the patients are not going to really have a fluid volume overload because, again, they're going to be get to a point where they're actually excreting more of this fluid out, and so it kind of reaches this homeostasis where even though the total body water is increased, they don't appear to be fluid overloaded. It's just enough to cause a dilution of the sodium to make the hyponatremia. So the most common cause you're going to see here is going to be SIADH, or the syndrome of inappropriate antidiuretic hormone release. So the most common causes of this are going to be things like small cell lung cancer, pancreatic cancer. Certainly, if you ever work in like a surgical or neuro ICU, you see this a lot with like stroke or head trauma. Meningitis can be a cause. Certain pulmonary disease like pneumonias or ARDS. And then in some cases, you can even see primary or psychogenic polydipsia being an issue with this. So some patients end up intaking over 20 liters per day of fluids due to whatever cause, and there could be several. The other big thing to note here is there's lots of drugs that can cause an SIADH. So it's again causing an inappropriate release of antidiuretic hormone. So some drugs that can cause increase in actual release of the hormone would be things like tricyclic antidepressants, some opioids, your vinca alkaloids, haloperidol, even nicotine can be seen linked to this. Certain drugs may actually increase the kidney's sensitivity to antidiuretic hormone to make it work better. So you can see things like lamotrigine or carbamazepine here. But certainly even acetaminophen has been known to cause it rarely. And then some agents will actually have mixed action. So everyone's favorite amphetamine, methylene dioxymethamphetamine, or ecstasy, MDMA, has been seen to cause kind of both actions. ACE inhibitors have been known to do this, and even SSRIs, like things like fluoxetine and sertraline, have been seen to cause this as well. Patients who may have a hypervolemic hypotonic hyponatremia, essentially what's happening here is you have issues where kidney sodium and water excretion are going to be impaired. So basically the expanded extracellular fluid volume and edema can occur, but basically a decreased effective arterial blood volume. So again, it's going to cause further sodium retention and further volume expansion and edema. So it kind of has this kind of cyclical effect here. Most commonly, you're going to see this being related to things like cirrhosis or CHF, and even nephrotic syndrome. So cases where they're going to be pretty edematous regardless. So the clinical presentation of hyponatremia, chronically, so say greater than 48 hours or so, mild hyponatremia, say in the area of 125 to 134 milliequivalents per liter, generally going to be asymptomatic for the most part. When you do have symptoms, though, they're mainly going to be neurologic in nature, and the severity of symptoms really depends on the magnitude and also the rapidity of onset of hyponatremia. So mild symptoms may include just nausea, malaise. As you get to more moderate depletion of sodium, say 115 to 124, this is when you can start to see more disorientation, lethargy, headache. And then the very severe cases, they say 110 to 114. This is really panic values. You can see seizures, coma, brainstem herniation, just due to the fact that if your serum sodium is so low and your brain does not really have a chance to equilibrate, it's going to have a higher osmolality and draw more water into the brain, which can cause herniation and edema to occur. And then death is certainly possible here. So laboratory tests, obviously, serum sodium is less than 135 would be considered to be low for the most part. And then you can also utilize sampling of serum osmolality and also urine sodium to kind of help with your diagnosis. Kind of tells you where the issue is really lying, if it's more in the kidneys or more in the serum, what's going on there. Obviously, if you're concerned about something like a DKA patient having hyponatremia, could be related to the glucose. You want to check that. You want to look at like kidney function, thyroid function, all those sort of things. And obviously, the biggest thing you're worried about is going to be cerebral edema. This is going to be the most kind of life-threatening issue. So again, so related to the speed and the degree of change in serum osmolality, and really your brain needs time to compensate the big changes in serum sodium. So say 48 hours maximally, because again, things don't like to come in or out of the brain very quickly for the most part, because it's kind of a protected area. So again, like I said, low serum osmolality is going to cause an inward shift of fluids to the CNS, and that's what causes the cerebral edema and eventual brainstem herniation. Now, correction of hyponatremia can be very, very dangerous in some cases, especially if it's done too quickly. So replacing serum sodium too quickly leads to a lot of neurologic consequences. So essentially what happens is if I have a big increase in your serum sodium, water's going to want to go from area of, it's going to want to go to where the high concentration of sodium is. So it's going to shift out of the brain cells into the intracellular, shift out of the brain cells and the intracellular fluid and move to the extracellular fluid. This leads to an acute decrease in the brain cell volume. And what happens is you have this this phenomenon called osmotic demyelination syndrome or central pontine myelinolysis, where basically the neurons start to just demyelinate. You're not able to have good conduction of action potentials, and so what you end up seeing is that this can happen, say, 1 to 7 days after treatment, but hyperreflexia, quadriparesis, Parkinsonism, it's kind of locked-in syndrome where they just can't move, and death can occur. So this is a big deal if you replace their serum sodium too quickly. And so there's lots of things in place to try to help prevent you that in a lot of hospitals. Again, the more cerebral adaptation that's occurred, the more cautious you have to be in correcting that serum sodium. So again, if I have, say, a very acute loss of sodium, so say a good example of this I had when I was in rotations was when we had a patient in the ICU who had, she's kind of a middle-aged lady who was very out of shape but decided to go into these boot camp classes. Again, this is Jacksonville, Florida in the summertime. It was hot as all get out, and she was just not really that well in shape. So she basically was out in the sun, had lots of fluid volume losses, was drinking nothing but water. So basically caused herself to dilute out pretty significantly, had a big change in her serum sodium. But this was over the course of, say, just a few hours. When she ended up getting replaced too quickly, it didn't really have any kind of long-lasting effects because the brain hadn't had time to adapt to it. However, if you have a patient who, say, has been a week and their serum sodium has been sitting in the low 1-teens, their brain's had time to adapt. And if you replace that serum sodium too quickly and they develop this demyelination syndrome, that's pretty much it for your patient. So you definitely do not want to be caught in that situation. And you always want to be very careful when replacing serum sodium. So obviously when you have hyponatremia, the idea is to treat the underlying cause of the hyponatremia, whatever it happens to be. Certainly if it was drug-induced, you want to discontinue the drug, find whatever the causative agent is. Now again, treatment of hypotonic hyponatremia must balance the risk of the hyponatremia versus the osmotic demyelination syndrome risk. So essentially, the idea is if your patient is seizing because they have no serum sodium, you need to replace that. So you're going to kind of give them sodium to help get them to a point where they're not seizing anymore or having significant CNS effects. And then once you kind of get them to a safe area from that standpoint, then you want to be very slow in replacing them so you kind of limit your risk for this ODS. Again, if your patient is still seizing, they're probably going to die from that before they do the demyelination. When you want to have correction of a hypovolemic hyponatremia, you want to give NS, or normal saline. Again, because of the fact that the extracellular fluid volume is low, your plasma volume is low, you can replace this with NS. That's not going to be a problem there. Now, on the other hand, when you have a euvolemic or hypervolemic hyponatremia, it really needs to be managed with water restriction. We'll talk about a drug called demeclocycline. We'll use antagonists of arginine vasopressin, or we'll utilize sodium chloride, normal saline, plus a loop diuretic. So we'll talk more about that in just a little bit. And if you're having any type of severe hyponatremia, symptoms of that, say seizing, significant ultramental status, this is where you can use concentrated sodium chloride. So that's where the hypertonic saline, so like 3%. I've even been in some institutions where they're utilizing 23.4% sodium chloride to help manage these acute symptoms of significant hyponatremia. So again, treatment, if you're having acute or severely symptomatic patients, really should be managed with hypertonic saline, either 3%, which you can see here is pretty concentrated at 513 milliequivalents per liter, even 23.4%. It's a very, very concentrated form there. Now, most patients generally require around a 5% increase in serum sodium in order to help kind of get over the hump for a lot of those significant CNS manifestations. Some people target a basement of 120 milliequivalents per liter. Below here is when you start to see more of the CNS effect, or it's kind of significant CNS effect. So generally 120 is kind of a safe place to shoot for. Certainly if your patient becomes less symptomatic below that, no need to replace this too quickly, because again, you always want to worry about that demyelination risk. And then another big thing to look at is you want to compare the urinary sodium concentrations to your corrective fluid. So say for instance, if you have a patient who has very concentrated urine in a case of SIADH or high serum or high urine sodium concentrations, you can actually make this worse by giving 0.9% sodium chloride, because you're basically just giving free water that can be reabsorbed, and it can lead to more fluid overload. Other things can be used to help prevent this would be things like loop diuretics, can be given to help kind of get rid of some of the extra free water if you're having to give a lot of fluids to help replace these patients. Patients who are having a hypovolemic, hypotonic hyponatremia, essentially you can give them 0.9% sodium chloride to help correct the hyponatremia and the hypovolemia at the same time. Now, if you have hypervolemic patients, so they can oftentimes be kind of difficult to treat. Sometimes you have to utilize, because of their volume status being kind of high, you have to utilize concentrated sodium and also something to help get rid of that extra free fluid. So you can utilize loop diuretics in these cases. So when looking at a patient, how do you determine how much sodium chloride you should be giving to a patient? And so there's lots of calculations that are out there. This one's pretty useful in figuring out how much sodium I need to give these patients, how much fluids I need to give in order to help replace them. So here, what you want to see is your change in serum sodium. So basically what you do is you look at your sodium concentration in your IV fluid minus the sodium of this in the serum, which again, if you're hyponatremic, should be lower than whatever fluid you're giving. You're going to divide that by the total body water plus the volume of IV that you're given. So essentially for a given volume of fluid, I can see how much of a change I'm going to see in my serum sodium. I'll show you some calculations here in just a minute. To get an estimate of total body water, essentially what you do is multiply, for men, you multiply them by 0.6 liters per kilogram, and for women, 0.5 liters per kilogram. This is related to, typically women are going to have a little bit more adipose tissue, and so they have a little bit less free water than guys do. The goal here is to generally achieve a sodium of 125 over to 130. And again, in the first 24 hours, you typically do not want to correct faster than 12 milliequivalents per liter. So that's a really important number to remember. Again, if your patient is acutely seizing because their sodium is 105, you got to replace that to get them fixed up. So it may be more than 12 milliequivalents, but again, if you have a patient who's relatively more stable, that 12 milliequivalents per liter is a good number to hold to for that first 24 hours. So as an example, if we had a patient who is, say, a 66-year-old woman who presented to the ED for vertigo and disorientation, she'd actually started carbamazepine about 10 days ago. So that should kind of ring off in your head, hey, I remember carbamazepine can cause hyponatremia because it causes an SIADH. When you check her serum sodium, it's found to be 108 milliequivalents per liter. That's actually be pretty significant hyponatremia. But step one, what would you do? Start carbamazepine. Stop that carbamazepine, obviously, because again, that's your causative agent there. And then looking at your desired serum sodium concentration, you want to look at shooting for around a basement of 120 milliequivalents per liter. Again, try not to do more than 12 milliequivalents per liter in that first 24 hours. So looking at how much to, say 3% sodium chloride to infuse, basically you just plug this into your calculation where you're looking at the concentration of sodium within the 3%, which is 513 milliequivalents per liter, and then you're going to subtract out your serum sodium of your patient, so say 108. Then you're going to be looking at their total body water, which is going to be, because she's a female, it's going to be 0.5 liters times her 60 kilograms. And then you're going to be adding plus 1 liter. So this is basically the change in serum sodium that I would get if I gave 1 whole liter of 3% sodium chloride. Calculating that out would be basically 405 milliequivalents per liter over 31 liters, and that basically turns into around 13 milliequivalents per liter of, or basically my change in serum sodium I would see for every liter of 3% saline I gave. I would basically be getting a change of 13.06 milliequivalents per liter. So now that I have this number, what I can do is look at a desired change is around 12 milliequivalents. So I can say multiple or divide that out. So roughly I would need to give around 919 mLs of 3% sodium chloride over a 24-hour period. Right? Pretty easy math once you do a couple practice problems or have a couple practice patients to use this on. So what if you wanted to use sodium chloride instead? So looking at here, I need a little less than a liter of 3% sodium chloride. Let's see how much that would compare with a liter of normal saline. So again, looking at the math here, say you have 154 milliequivalents per liter of sodium minus your 108. Again, the calculations are all the same here. And basically what you end up getting is that for every liter of sodium chloride I give, I'd see a change of around 1.48 milliequivalents per liter. So pretty significantly less change than I would see if I was giving 3%. So then figuring out how much I would need to give over a 24-hour period to change her serum sodium by about 12 milliequivalents, I'd have to give 8.1 liters. So 8 times more volume I'm having to give if I was going to use normal saline versus 3%. So you can see just due to the volume maintenance, especially if this patient had kind of bad kidneys or bad liver, this is not someone you want to give a ton of fluid to potentially. So this is why you utilize hypertonic solutions like 3% in order to help replace these patients. Again, treatment, if you have non-emergent hypovolemic hypotonic hyponatremia, so this would be patients who are relatively stable, maybe having some CNS manifestations, but they're relatively stable. Here in these situations, because they're already volume depleted, you typically want to utilize normal saline over 3%. This helps to limit how your risk of overcorrecting them too quickly, and it's also going to help replenish their volume. So in these cases, you'd want to use definitely NS over 3%. Now, if you have non-emergent euvolemic hypotonic hyponatremia, so again, if you have like a management of SIDH you're having, this is where the biggest thing you can do here is not necessarily to give them more sodium, but to help restrict the amount of water they have taken in. This helps to correct the underlying disease. So obviously, if you have some offending agents, some drugs that are causing this, you want to get rid of those if you can. So like in our past situation, we saw carbamazepine might be a causative agent here. And you really got to restrict their water intake to 1,000 to 1,200 mLs per day. I'll never forget, I had one patient in the surgical ICU that had a significant head trauma. and we know that SIDH can be caused by a head trauma. And so this patient was, significantly hyponatremic, and the goal here was to limit how much sodium or how much water they were intaking. So we put them on water restriction, and the lengths that this patient would go to try to get more water due to the thirst response that they were getting from this increased levels of antidiuretic hormone is amazing. They would sneak out of the room, they would sneak down to the cafeteria to try to get more water. They would have family members try to sneak it in, just due to this like huge increase in their thirst response from the ADH being released. So it's really kind of dramatic to see just how significantly the patient can be affected by this. So hopefully you limit the amount of sodium they're going to be, or limit the amount of fluid they're going to be intaking, and then you also want to limit, um, you want to increase their sodium intake by giving sodium chloride tablets, and/or a loop diuretic. Loop diuretics can help get rid of some of that extra fluid, and the sodium chloride tablets are just kind of a volume-free way to increase their sodium. Some other things we can utilize to help limit the activity of ADH, some antagonists would be one is dimethylcycline. This is actually a tetracycline derivative. Doesn't really have any good antibiotic activity, but is very good at inhibiting the tubular activity of arginine vasopressin or ADH. And so essentially what you end up seeing is kind of this diabetes insipidus that is being developed, where you're going to be losing more free water, hopefully holding on to more of that sodium. Takes a few days to kick in, say around 3 to 6 days. And you don't want to give it to patients with either liver disease, because that can be exacerbated by this, or who have kind of a compromised fluid intake. Because of that, you can end up seeing renal tubular toxicity or acute kidney injury. So again, not something you want to do on top of the SIDH you already have. Again, because it is a tetracycline derivative, you do want to limit use in patients who are less than 8 years of age or those who are pregnant, just due to the staining effect that these drugs can have. Other drugs that can be utilized for the management of SIDH would be your vasopressin receptor 2 antagonist. It can be shortened up to your Vaptans. So this would include things like Conivaptan and Tolvaptan. And essentially what these are doing are they're going to be decreasing water resorption in the kidneys by antagonizing that V2 receptor. So you can consider them to be an aquaretic. They cause to urinate more just free water. So Conivaptan is going to be IV only, so you typically will only see it in hospital use. But Tolvaptan is as an oral preparation, you can potentially being used for more chronic management of SIADH. It is metabolized by CYP3A4, so it's important to remember your drug interactions there. And it's going to be contraindicated in anuric patients, because this is going to be stimulating more urine output, and so if your patients have bad kidneys, this can lead to some issues here if it's not really being that effective. And can also lead to some risk for hepatic damage or failure. So it would be contraindication in patients with already pretty significant hepatic damage. Again, this is not going to be appropriate for emergent correction of serum sodium. This is going to be more for non-emergent, more chronic management of the disease state. Those patients who have a hypervolemic, hypotonic hyponatremia basically need to have a net negative water balance while trying to minimize changes to the intracellular volume. So again, you want to correct the underlying cause if you can. And here, what we can do is try to limit fluid intake and also limit our sodium intake as well. Again, these are typically going to be issues where patients are having a problem getting rid of fluid in the first place. If we can do things to improve things like cardiac contractility, that's going to be useful. So things like digoxin for your CHF patients, or like ACE inhibitors that can help reduce afterload. Probably more evidence supporting use for that, but all those things can help basically to try to get the body to process the fluids a little bit better, and that'll help to get your sodium back into control. Moving on to hypernatremia, this is typically going to be occurring from either renal or extrarenal fluid loss. You can see it when you have hypertonic fluids being given, or if you have excess sodium ingestion. So certainly going to say your favorite Chinese buffet, you're going to have a lot of sodium ingestion that can lead to a potential hypernatremia if you have, say, poor kidneys to be able to process that. Typically, the characteristics you're going to see if you had a hypovolemic hypernatremia, that's going to be related to more to things like diuretic use, post-op diuresis, renal losses of free fluids. If you had a euvolemic hypernatremia, That's oftentimes related to diabetes insipidus or primary polydipsia. And then if you have a hypervolemic hypernatremia, this can be related to sodium overload. You can see if people were being given sodium bicarbonate or salt tablets, they had very concentrated tube feedings, or sodium-containing medications can lead to a hypervolemic hypernatremia. Again, water loss is typically going to be occurring through kind of insensible losses, and frequently what you end up seeing is the patients are not given enough free water to kind of account for this, especially if they're in a high stress state or they had burns and things like that. They're losing a lot of water, and so oftentimes we're not giving enough free water to kind of account for this. So then also possible that you can have an issue of diabetes insipidus, where again you're going to be having lots of causes for this, but essentially one of the big ones is going to be that can occur centrally if you have a decrease in the amount of arginine vasopressin, or if you have less antidiuretic hormone. That can be a problem there, or potentially you can have nephrogenic causes where basically the brain is putting out arginine vasopressin appropriately, but the kidney has a decreased response to it. So we'll see there are going to be some drug-induced causes of this as well. And so essentially what we end up seeing is you have a large volume excretion of dilute urine. It's not really all that concentrated. So your serum sodium ends up getting concentrated because you're losing all this free water within the urine. Some of the causes we can see of diabetes insipidus centrally. So if you have a hypodipsia, you're not really intaking enough fluid, neurosurgery or head trauma, CNS malignancy, this can all be big causes for this. And also ethanol ingestion as well. You've ever heard the term breaking the seal? That's basically because ethanol causes a decrease in the release of arginine vasopressin or antidiuretic hormone. So that's why you end up having to urinate more frequently when drinking ethanol. As far as nephrogenic causes, we will see more drugs being involved with this. So amphotericin B, which we've already talked about, is a potential cause for diabetes insipidus. Lithium is going to be another big one as well. And so one of the things you want to watch out for your patients is going to look at both fluid status and also look at serum sodium to see if that's being affected by that. And then obviously dimethylcycline, your Vaptans, those are all things that work to inhibit the effects of arginine vasopressin. So certainly they're going to induce their own diabetes insipidus, which could be therapeutic if the patient has SIADH, or it could be detrimental if they're using it for anything else. So again, clinical presentation, you're going to be seeing a shift of fluid from the intracellular space to the extracellular space. You're going to be having polyuria associated with this, and typically you're going to have kind of very dilute urine being formed. The symptoms are going to be caused by this are going to be related to this decrease in neuronal cell volume. And so certainly you can see things like weakness, lethargy, irritability, confusion, and then also you see more significant CNS effects as you get much higher sodium concentrations, so say 160 or higher. Typically you'll see that patients can handle high sodium concentrations much better than low sodium concentrations for the most part. So certainly I've seen more patients have issues with, say a serum sodium of 115 or say something like 120 versus say like a serum sodium of 155. They tend to handle the hypernatremia a little bit better. And typically you're going to see that the acute onset is going to be more symptomatic than the chronic, because again your body doesn't really have time to adapt to this if it happens very, very acutely. So your treatment goals, you'd like to get your serum sodium back down to 145 milliequivalents per liter. If you have too rapid of a correction, it can lead to cerebral edema and seizures potentially. Again, that's related to if the CNS has had time to really equilibrate. And so if you were to lower your serum sodium much more quickly, that means the solute concentration is going to be higher in the CNS, and that can lead water to travel across the blood-brain barrier and lead to that cerebral edema. Again, typically what you can do is help to continue sodium restriction and encourage fluid replacement to help prevent recurrence of further hypernatremia from popping back up again. So in regards to pharmacologic therapy, if you have a hypovolemic hypernatremia, typically what we want to do here is utilize sodium chloride, just normal NS, until the volume is really restored. And then at that point, you can actually switch to a lower sodium containing fluid, like something like half normal saline or even D5W. That will help to bring the serum sodium down a little bit more slowly. So by using NS up front, you don't really overcorrect so much until the volume's restored, and then you can utilize less sodium to kind of get them back down to a normal range. Very similar to what we saw with hyponatremia, correction should not really exceed 10 to 12 milliequivalents per liter per day. Again, if it occurs quickly, several hours, you can correct. Or if the hypernatremia came on very quickly, you can correct a little bit faster. So typically around 1 milliequivalent per liter per hour. But certainly, if it's more chronic, 10 to 12 milliequivalents per liter per day is really your max. If the patient has a central diabetes insipidus, we can replace the AVP that the brain is not producing by giving them exogenous AVP or utilizing a drug called desmopressin or DDAVP. It's pretty poor oral bioavailability, so oftentimes you'll see a nasal formulation or an IV formulation being made or being utilized. Basically, you just adjust your dose to achieve adequate urinary concentrations. This can also be utilized to help prevent urination during sleep. Sometimes you'll see, to prevent nocturia, you can see a DDAVP being utilized because, again, it's antidiuretic hormone essentially, so it's going to cause you to not urinate as much. And then desmopressin does have a risk of water intoxication because, again, it's going to be kind of stimulating that thirst response. So it may lead to issues of hyponatremia if it's not dosed appropriately. So if you have a patient who has nephrogenic diabetes insipidus, you can obviously discontinue the causative agent if one is available, and try to correcting electrolytes abnormalities that have occurred. So the real way to treat it, though, is going to be trying to induce a mild extracellular fluid deficit, around a liter and a half, by utilizing a thiazide diuretic and salt restriction to help cut the volume of the urine. And it seems kind of counterintuitive to use a thiazide diuretic to decrease urine outflow, but essentially what's happening is by decreasing extracellular fluid volume, you're going to be increasing the proximal tubules water reabsorption, and this decreases the filtrate that's going to be delivered to the distal nephron. So basically what it's going to end up doing is causing a decrease in urine volume overall. Another drug which can potentially be used is an NSAID called indomethacin, which can actually help to potentiate the activity of any arginine vasopressins already being released there. If you're dealing with a patient who's just got sodium overload, obviously you want to limit sodium intake, and utilizing something like loop diuretics can help to facilitate sodium excretion in conjunction with something like D5, which is again going to be a lot more free water, which can help to dilute out the sodium overload. So that's the end of the nephrology section. Certainly if you have any questions, feel free to either email me or hold them till class, and we can talk about it then. Thanks so much for listening, and I'll see you guys next time.